to strengthen your coding skills. 5, practice Chun. 6, bring you one step closer to CPC exam readiness. Now, let's begin our instruction with this question. What is evaluation and management, or E&M? What is it? All right, I'll tell you. No, I'll engage you, and then you can tell me. Evaluation and management is office visits, inpatient hospital visits, ER emergency room visits, consultations, nursing facility visits, and more. All right, coders, in the simplest way that you can, based upon what I've just said, what is an E&M, or evaluation and management encounter? Go ahead, type in the chat. What do you think it is in the simplest way? It's not a multiple choice question. Yes, you all are raining through the chat. Yes. Oh, I love it. You know what? Almost all of you are correct. Pretty much, they are doctor visits. Yes, they're doctor visits. Anytime the patient visits the doctor and anytime the doctor visits the patient, that is what an E&M encounter is in the most simplified way. So we are going to learn to code for these office visits because there are different types of doctor visits. We're going to just talk about office visits today, and you're going to know why in a moment. But first, let's review the guidelines. Well, the table of contents, then we'll review the guidelines. All right, so in the table of contents, you'll find your guidelines, your 4 green bold items here. Then next, I apologize. The guidelines for hospital observation, inpatient consultations, emergency department, nursing facility, domiciliary, rest home, or custodial care, and home E&M services. Here are guidelines for instruction for selecting a level of E&M service for hospital observation, hospital inpatient, consultations, emergency departments, nursing facilities, domiciliary rest homes, or custodial care, and home E&M services. Here is the guidance for office or other outpatient E&M services. This is what we're going to talk about today. Instructions for leveling the service in this office or outpatient setting. We're going to learn that today. They have unlisted procedures, special reports, and clinical examples. And next, this is your table of contents. Next, our guidelines. All right, so this is still the table of contents too, just expanded version. In evaluation and management, you have office or other outpatient services. This is where you'll find the guidelines. You'll find guidelines for observation services, for inpatient services, consultations, emergency department, critical care, nursing facility, domiciliary rest home, or custodial care services. And the domiciliary rest home, assisted living facility, or home care plan oversight services, that is different. You've got your home services, prolonged services we're going to talk about today to some degree. We're going to talk about case management, care plan oversight services, preventive medicine, non-face-to-face services. And we're going to round things off with special evaluation and management services. This is where you'll find the guidelines for newborn care services, delivery, birthing, room attendance and resuscitation services, inpatient neonatal intensive care services, and pediatric and neonatal critical care services, cognitive assessment and care plans, care management services, psychiatric collaborative care management services, transitional care services management, advanced care planning, general behavior health integration care management, and other evaluation and management services. Ladies and gentlemen, this represents all of the types of doctor visits that you can code for and their guidelines. All of them have their own guidance. But today, we're going to discuss office visit encounters. And did you know that office visit encounters have different coding rules and guidance? And they are significantly different than all of the other E&M sections. So you might say, why are the office visits coded differently than any other E&M visit? Well, most providers carry out visits, right? People go and visit these doctors. And also, during these visits, they don't really carry out procedures. They just talk. Sometimes they talk, they document. They're not doing a procedure. So, all of this talking required the doctor to document, right? Yeah, so the doctor was doing a lot of writing. And the doctor really wasn't paying attention as much as they could to the patient. So, in essence, the powers that be, namely CMS, CPT, and advocates, people that advocated for the physicians and providers, they really wanted the shift to be on the patient, not the paperwork. So there was an ideological shift in E&M services. And I don't know if you noticed. I don't know if you've noticed, but I felt like since the mid 1900s, like 1995, okay, not 1900, but from around 1995, I really felt like the provider was more focused on the paperwork. Yeah, I really did. At some point, I said, when I would go to the doctors prior to that, we will remove our clothes so that they can do an examination for an annual visit, like a preventive medicine visit. I remember doing that. And then all of a sudden, I remember that I no longer removed my clothes. There was no physical examination, and there was more focus on that computer. The doctor was sitting behind the laptop and just asking me all these questions. So now, just recently, as early as 2021, the doctors reclaimed the patient. Their focus is now more on the patient, right? And they have a reduction in administrative burden, meaning they don't have to do as much paperwork. And we are going to talk about why. I'm going to show you why. So, for office visits, the paperwork is less than the other visits. But rest assured in knowing that the others are going to follow suit. Remember, this change has just taken place. Now, let's get in and let's talk about the guidelines pertinent to evaluation and management. Now, these are the guidelines pertinent to all evaluation and management services and its office visits as well. I'll point them out. All right, so the E&M guidelines overview. This is pertinent to office visits. Your classification of evaluation and management, or E&M services. Pretty much just letting you know all of the classification of visits that are coded in this section of CPT. Definitions of commonly used terms, guidelines common to all E&M services. Let's go back. I don't want to move too fast. We can let that marinate. Also, the decision tree for new versus established patients. Guidelines for time. If you see it in the blue bold with this yellow glow around it, that means it's pertinent to office visits, our discussion today. Also, our guidelines for hospital observation, hospital inpatient consultation, emergency department, nursing facility, domiciliary, rest home, or custodial care. These are some of the guidelines. Instructions for leveling an E&M service for everything except an office visit is here. Now, here are the guidelines for office or other outpatient E&M services. They are all here. Now, oh, look at this. Just want to point this out. We're going to talk about definitions. They are listed here. Definitions. All right, just so you know, your definitions are here. Also, instructions for leveling an office or outpatient code is here. And we'll talk about what leveling is. And if you've watched the lecture, you should have an idea of what leveling is. And finally, unlisted codes. Also, with unlisted codes, you too have to submit a special report. And finally, we have clinical examples. These are additional scenarios if you want to test your knowledge. All right, let's begin with first, from your panel, from your handouts, not handouts panel, I didn't put it in there, from your chat, you should get a link. So I need one of my team members, to provide oh, it's not here. So don't worry about it. But there is, this is also in your, I just showed you, it's in your CPT manual. And before this presentation's over, I'm going to give you the link, because we're going to talk specifically about these definitions. But just so you know, I'm going to give you a link for handouts for definitions. And it's important. And you're going to know a little, very soon why these are important, understanding these definitions. All right, so now let's get to the business of coding office visits. Pretty much, office visits are partially determined, or how to code for office visits are partially determined by whether or not the patient is new or established. Is this patient new to the practice, or is this an established patient? So how do we determine whether the patient's new or established? Well, the guidelines, of course. In your CPT manual, under the guidelines for office and other outpatient visits, you'll find that the guidance for a new patient. A new patient is described as a patient that is new to the practice, never been there before, or that patient hasn't seen the physician within the past 3 years. All right? An established patient is seen within 3 years. So that's a patient that was seen within 3 years, and any doctor of the practice of the exact same specialty and subspecialty is applicable. So if the patient was seen within 3 years by their doctor and any other doctor within that practice of this exact same specialty and subspecialty. So here is where you can find that guidance. All right. Are you with me? Go ahead and type in the chat. Let me know. All right. Good deal. So I'm going to give you a little example. All right. Here we go. So here's a scenario. We have these two doctors, Dr. A and Dr. B, and they are internists who work for a company called Medical Associates Incorporated, right? They both are internists. However, Dr. B also went to school to specialize in general oncology, right? So Dr. B went for a little more education. So when we look at Dr. A and B, Dr. A is an internist with a specialty in general medicine. Dr. B is also an internist with a specialty in general medicine and has a subspecialty in oncology. So, Dr. A and B, they have the same specialty and but they do not have the same subspecialty. Therefore, they are not considered to be the same doctor. So, moral of the story, if Dr. B covers for Dr. A, that patient will be coded as a new patient. There's no way they can be regarded as an established patient. Let's assume that it's within the 3 years. They cannot be an established patient because both doctors are not of the same specialty and same exact subspecialty. All right. So CPT has this really nifty decision tree, right? So in the beginning, where the guidelines are, and I think I showed you a few moments ago, if you don't know if a patient is new or established, you can use this decision tree. So let's take Dr. A and B. They ask the question at the top of the decision tree. It says, the patient has received any professional service from the physician or qualified healthcare professional or another physician or qualified healthcare professional in the same group of same specialty within the past 3 years. So essentially, has this patient been seen? And we're going to say yes. Then we're going to say, do these two doctors have the exact same specialty? Relevant, if it's relevant, then you say yes, because they do have the exact same specialty, both Dr. A and Dr. B. Well, what about the next question? Do they have the exact same subspecialty? Well, that answer would be no, because Dr. B has a subspecialty in oncology. So therefore, we're going to have to classify this patient as a new patient. So hopefully this you'll find this decision tree helpful. All right. So now let's get on to the business. But before we get on to our discussion, I want to know what you already know about E&M coding and how familiar you are with the new and established patient. All right, quick question. True or false? A new patient is one who has not received any professional service from a physician or qualified healthcare professional within the past 2 years. True or false? Type your answer in the chat. You all are rocking, 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 rocking. Good job, good job, good job. All right. Yes, outstanding. 90% of you have said false. And that is correct because it's not 2 years, it is 3 years. So for those of you that didn't get it correct, it was probably you moving fast, or this is an aha moment and that is priceless. Now, let's get down to the business. Good job, everyone. Our discussion today pertains to E&M office or other outpatient encounters, code series 99202 through 99215. And we're going to also talk about prolonged services visits that are related to office visits and others. 99354, 5556, and 99417. But first, let's turn our attention to the office visit. All right, coders. So pretty much when a doctor documents documentation, okay, when they write in the patient's chart, that will determine the level of service. And doctors can choose whether or not their documentation is based on the total time of the encounter or the MDM. I changed this. I'm going to change it right now. It is called the MDM. There you go. MDM, medical decision making. Let's see if it'll change for you. Hmm. Let's try it one more time. There it is. All right. So what does that mean? That means that the coder will select the code based upon time or MDM. So let's learn how to select the level of service based upon the total time of an encounter. All right. So this is how it's done. First things first, the activities, the qualified activities that a provider should do during a time-based encounter, a total time-based encounter. They can prepare to see the patient. They can obtain and or review separately obtained history. So they can do a history. They can perform a medically appropriate exam or evaluation. They can counsel and educate the patient, family, and caregiver. They can order medications, tests, or procedures. They can do referring and communicating with other healthcare professionals when not separately reportable. They can document clinical information in the electronic health record. They can independently interpret results, not separately reported, and communicating those results to the patient, family member, and caregiver. And finally, they can carry out care coordination, which is not separately reportable. So these are all of the activities that a physician or qualified healthcare professional can carry out when documenting total time of an encounter. So now let's take a look at the codes. And these don't look like your codes in your manual. Just pay attention to the code. I have it really big so that we can really explore the language, but specifically the total time of each code. So if we look at 99202, the total time of the encounter is 15 minutes and to 29 minutes. So the code reads office or other outpatient visit for evaluation and management of a new patient, which requires a medically appropriate history and or exam and straightforward medical decision making when using time for code selection. So essentially, you can use the total time of the encounter that satisfies the code language. Now let's also note that these are the codes for new patients. So if you want to use O3, the total time will be 30 minutes to 44 minutes. 99205, the total time of that encounter has to be between 45 to 59 minutes. 99205, The total time has to be 60 to 74 minutes. And when that encounter is 75 minutes or more, you have to go and see that prolonged services code 99417. So we'll talk about that a little later, but it's most important that you understand that total time is going to drive your code. Now let's go ahead and look at our established patient codes. 99211, does not require any time, just to let you know. This is the nurse's code, 99211. But 99212 is 10 to 19 minutes. 99213 is 20 to 29 minutes. 99214, 30 to 39, and 99215 for 40 to 54 minutes, and anything longer than 55 minutes needs a prolonged services code of 99417. Now, I think we're ready. We are ready to go ahead and apply to practice what you've learned very briefly. um, how to select the E&M code based upon time. So here is our guidance. Number one, you have to determine if it's a new or established patient. You need to determine that because, as you've seen, we have new and or established codes. Number two, we have to make sure that the doctor's PHP activities are eligible. And three, what is three? Three is select the total time of the encounter. Now, keep in mind, these are the activities that are eligible. So we have to select the total time of the encounter. Now, are you ready to test your knowledge? Some of you might say no, but others are saying, yeah. Guess what? This is going to be so straightforward. You're going to love it. I promise. All right, here is our scenario. A 37-year-old female patient with a history of dyslipidemia and chronic pain arrives to her PCP's office for follow-up of lower extremity swelling. The patient indicates that the swelling responded to hydrochlorothiazide. Limited exam was carried out, and her labs and echocardiogram were reviewed. The patient does have moderate pulmonary hypertension. Final diagnostic assessment, bilateral lower extremity swelling, improved with diuretics. This may be secondary to pulmonary hypertension. Etiology is not clear at this time. We'll do a workup and possible referral to a pulmonologist. Plan. I think we will need to evaluate the etiology of the pulmonary hypertension. The patient will be scheduled for a sleep study. Total time of encounter, 30 minutes. What are the CPT code or codes reported? All right, you have 1 minute to solve. Yeah, 1 minute. And your time begins now. All right. Someone asked, hey, what are the keywords? Your keywords are pretty much going to be up here in the right. You have to be able to answer these questions on the right. All right, so I'll demonstrate how to do it. So you all, I think for the most part, have done amazing, and some of you are going to have an aha teachable moment. All right, here are my keywords. And just so you know, up at the top, this is what you're looking to do. Down below, these are some eligible activities, but you still need to have your exam. Definitely an exam is required. All right, so keywords, pretty much the diagnoses: dyslipidemia, chronic pain. Follow up keyword: lower extremity swelling. Limited exam, labs and echocardiogram, reviewed, bilateral lower extremity swelling, pulmonary hypertension, and the most important of them all, total time of encounter, 30 minutes. Now, let's go ahead and solve. My keywords are on the left. On the right, here are my instructions. Is this a new or established patient? We know that this is an established patient because the patient came for a follow-up, right? So you don't follow up if you are a new patient. That's your keyword. And if you didn't know, that's your teachable moment. And you're going to see that a lot. All right, number 2. You have to make sure that the doctor or PHP activities are eligible. Those eligible activities right here. And as you can see, the doctor did carry out a medically appropriate exam and evaluation. For a moment, because you all did not, everyone didn't watch the lecture, we talked about what a medically appropriate evaluation is. That's pretty much at the doctor's discretion, right? So if the doctor carried out a limited exam, that exam was indeed medically appropriate. So number 2 is good. And 3, we need to select the total time of the encounter. The total time of this encounter, 30 minutes. Everybody with me? All right. Now let's get to the good stuff. I'm going to put my little code series here. This is an established patient, so I'm going to the established patient codes that begin 99211 through 99215, and I'm going to look for the code that my 30 minutes falls under. And if we look at code 99214, this is the code for total time 30 to 39 minutes, and ours is 30 minutes. So it's that simple. Our evaluation and management level of service is 99214. It is that's our moderate level of service. All right, how do you feel? Good, good, good. All right, outstanding. All right, so now I'm going to hand it over to Ms. Takima, and she's going to continue the discussion on selecting the level of service using total time.
Thank you, Mrs. J. Thank you, coders. And here is your next scenario. Susan is a 67-year-old female referred by Dr. R with a suspicious neoplasm in her left arm. She's had it for about a year, but it's grown a lot in the last few months. He had the privilege of taking a skin cancer off her forearm in the past. There's a past medical history of hypertension and arthritis, no allergies. She's on Benicar and Vytorin. She does not smoke. Her physical exam shows a raised lesion, a little bit red on her left proximal arm. It's a little bit bumpiness on the surface. His medical decision making is suspicious neoplasm left arm. My guess is that this is a wart, but it may be a keratocanthoma, as Dr. R thinks it is. After obtaining consent, we infiltrated the area with 1 cc of 1% lidocaine with epinephrine, performed a 3 millimeter punch biopsy of the lesion, and then shaved the rest of the lesion off and closed the wound with a 3.0 Prolene. We'll see her back next week to give her the results. Total time is 55 minutes. So what E&M code would you assign this scenario, coders? You have 1 minute. Okay, coders, that was a minute. So let's look at our scenario here. I think there is some confusion amongst us. The answer is not 99204, and we will show you why it's not. So our keywords here: a 67-year-old female referred by Dr. R. She has a suspicious neoplasm on her arm. She's had it for a year, but it's grown a lot. He took a skin cancer. So this doctor took a skin cancer off of her forearm in the past. She has a history of hypertension and arthritis. Those are your allergies, medication, social history. Physical exam is raised lesion, a bit reddish. It's a little bit bumpy, and it's on her left arm. He says suspicious neoplasm in the left arm, might be a wart, but it might also be keratocanthoma, which I can't say. He performed a 3 millimeter punch biopsy of the lesion and shaved the rest of the lesion. Total time was 55 minutes. So our first job is to determine if this is a new or established patient. If you look at the scenario, this same doctor removed skin cancer off her forearm in the past. So that makes her an established patient because he has seen her in the past. Okay, does that make sense to everybody now? I think that's where we got confused there. Our next step is to make sure what he did was eligible, and he did a history, he did an exam, he ordered tests or procedures, he was referring and communicating with other health professionals, which that with that referral from the other doctor, and I assume he documented his clinical information, so everything he did was eligible and eligible activity. So when we look at our chart, 99215, which some of you put, only has a time of 40 to 55 minutes, and it says 55 minutes or more, see prolonged services. See prolonged services. If you go to your prolonged services chart, in that section, you will see that 55 to 69 minutes is 99215 times 1 and 99417 times 1. There is also a note for an established patient. It has to be 15 minutes of time accumulated beyond the 40 minutes. I know that that's what gets people confused sometimes, because in certain sections of the book, it says just 15 minutes. It doesn't specify over that 40 minutes. So you might think it's 15 minutes over that 54 minutes for 99215, but it is 15 minutes beyond 40 minutes. So once they hit the 55 minutes, that is now a prolonged service code of 99215 and 99417. Okay, so hopefully that answered your questions about that, coders. Hopefully that made sense. And so this is not, so she was referred to this doctor. This is not a consult, because in this, he's just removing, he's performing a procedure. He's not looking at the cant or the whatever the lesion is at this point in time. He's not determining what it is at this point in time. She is at his doctor's office to have it removed and the biopsy done. Okay, so this would not be a consult, it would be an established patient that he had already seen in the past. Okay, and this chart is in the book in that prolonged services section. I'm not sure what the page is, but it's in that prolonged services section. Okay. Okay, so yes, I'm sorry, I don't think it was clear as to the answer between us. I think I changed the slide and everybody else had a different slide, but this is in fact our answer for here. Sorry about that. I do not know the page. Again, it's in that prolonged services section. I don't know the page. Okay, somebody says page 44. So page 44, try that. Or 43 in the 2021 book. So we can try that. Our next scenario on time. A 14-year-old patient, female patient with a history of cystic acne, arrives to her dermatology oncology initial visit for treatment. She was referred by her general dermatologist, who belongs to the same practice. The provider carried out a comprehensive history and exam and reviewed the patient's chart, which contained a comprehensive metabolic, renal, and thyroid panels with a skin biopsy. Final diagnostic statement is chronic cystic acne. Total time is 60 minutes. Coders, you will get 1 minute to solve this. Tell us what you think the encounter is. Okay, coders, that was 1 minute. And I think you guys read this one super forensically this time, because I see the majority of the correct answer. Our key terms for this one is a 14-year-old female, has a history of cystic acne. She's at a dermatology oncology initial visit for treatment. She's referred by her general dermatologist, who belongs to the same practice. The provider did a comprehensive history and exam, reviewed the patient's chart, which meant that he also reviewed the comprehensive metabolic, renal, and thyroid panels with the skin biopsy. His final diagnostic statement is chronic cystic acne, and the total time is 60 minutes. So if we look at our scenario, this is a new or established patient. We're going to figure that out first. she's visiting a dermatology oncologist for initial visit for treatment. She's referred by a general dermatologist in the same practice. But remember, our guidelines say for it to be a new patient, it has to have not received services from the physician or another physician of the exact same specialty and subspecialty who belong to the same group within the past 3 years. Both these doctors belong to the same group or practice, yes, but they do not have the same subspecialty. One is a dermatology oncologist, one is a general dermatologist. So this would be a new patient. This would be a new patient visit. So if we look at what his qualified activities were, preparing the patient, reviewing, separately time history, so all of his activities count. So we would just select our time, and our new patient times are listed here. 60 minutes falls within that 99205, and that's it. So there is not another code for this one. And I think you guys are confusing. Make sure you screenshot, or when you go back to the playback, screenshot the times listed here that Mrs. J did it for you for new patient and the times for established. These times are going to be different. 99205 is not going to have the same time as 99215. So make sure you're looking at the correct times. For a new patient, the largest category, 99205, is for 60 to 74 minutes. So our answer for that is 99205. Okay. And you guys did a great job on that one. So good job on that. And we will come back to Mrs. J.
Thank you, Ms. Takima. All right. So I have to do a little housekeeping because there's a little mistake here. So let me clean it up. And the reason why I have to clean it up is because if I don't, I'm going to have another mistake. And also too, it's good that we fix it right now while we can. All right, so here we go. Let me go ahead and take over the screen. So for the not the first scenario, the second scenario. All right, everyone see my screen? This is, everyone see me. So we have a 67-year-old female that was referred by Dr. R. Anytime a patient is referred, it's new. So that's where we got hung up. This is a new patient. And here's another thing. It says that he had done, I believe he had done a biopsy previous, but there were no dates here. It could have been 3 years, it could have been 4 years. So we have to use the documentation. And I want to make sure that everyone understands that. Yeah, this is a new encounter. So this is a great moment. Great moment. And also too, if you're looking in the documentation, she had it for about a year, we're going to assume that this was written material. This doctor has to unequivocally say, I've seen this patient. There is no mention of that. All right. So if it's new, we're going to follow the same protocol. You have to make sure that the doctor carried out the appropriate activities and that there is an exam, at least an exam. All right. So with that said, I got to change something in the back end, and I decided to do it at the last minute. This is a 55-minute encounter. So students, go ahead and tell me What is the code? If this is a new patient and the amount of time is 55 minutes, what is our code? Go ahead, type in the chat. Absolutely. 99204. That's indeed it. It is that straightforward. And I wanted it to be that straightforward. And when I saw that it was coming up, established, I said, how did I do that? Okay. So what I'm going to do, I want to make sure I print it out so you can see it. Hang tight. Got to get it on the screen. Okay, here we go. Just so you can see it. 99204 is your answer. All right. And you're going to see why I had to create that. I had to correct it. You say, why'd you have to do that, Mrs. J? Well, I kind of had to because we're going to duplicate these scenarios next. All right, now I'm going to get to my regularly scheduled program. All right. So, how was time without that little blip? How was time? Was it pretty straightforward? You just pretty much have to have an office visit and the time documented. How do you all feel? It's straightforward, right? Yeah. But what if? Yeah, you should feel pretty good with time. You just look at the time, make sure it's new or established. You really nail that. And then that'll drive you to the correct classification of codes. But what if the physician does not provide the time? What if the physician doesn't provide that time? I'm up here, moving things, and I think I'm going to have to move something else. So what if they don't provide the time? You're going to have to do this. You're going to have to score the MDM. Yes, score. Hey, you all have done some scoring, more than you know. Yeah, we're going to have to score the documentation. We're going to review the documentation, then score that documentation to determine the level of service. And pretty much I said MDM or time. In other words, the medical decision making of an office visit can determine the level of service or that code. So, what are the types of level of service for these MDMs? Well, we have a straightforward, a low, moderate, and high. And all of these levels have a code assigned to it. Now, when that encounter has a medically appropriate history and or exam, we can just go ahead and score the documentation to determine the MDM. So, in our Is it in your handout? No. In your CPT manual, there is a scoring table that looks like this, and they call it your medical decision-making scoring table or something like that. So this is how you read it. You'll see your codes on the left. It's a 99211 if you have the number and complexity of the problems that are addressed in that encounter or in that documentation are not applicable. It's a 99211 if the amount or complexity of the data analyzed is not applicable and the risk is non-applicable. Doesn't this table look familiar? All right. So it's a 99202 or 12 straightforward if the number and complexity of problems addressed are minimal or none for the data. And if the risk is minimal, it's minimal. 99203 and 13, it's a low. If the number and complexity of the problems addressed is low, then that will be low. It will be limited if they meet at least one of these two categories. In the first category, the test and the document, any combination of the following: review of prior external notes from each unique source, review of the results of each unique test, ordering of each unique test. So if the provider does any combination of two of those, you can say, all right, we've met the requirement for a low data, analyzation of data. Or if category 2, if an assessment required an independent historian, if that took place, you meet a low data reviewed analyzation score. It's moderate if from category 1, if they carry out all of the elements as they have in the low, in addition to an assessment requiring an independent historian, or category 2, independent interpretation of tests, or category 3, discussion of management or test interpretation. If at least one of these categories are met, this is a moderate data. Extensive data is when they carry out all of the same elements for category 1, 2, or 3, but the difference is they have to have at least 2 out of these 3 categories. So category 1 and 2, 1 and 3, 2 and 3, etc. All right. So finally, when we talk about risk is a little more subjective. You have a minimal risk of morbidity. You have a low risk of morbidity that is subjective up to the coder, but it's less subjective when you get to the moderate section, and they give you examples. If that provider had carried out prescription drug management, if the provider wrote a prescription, it's automatic moderate risk. If the decision regarding minor surgery took place, automatically it's moderate. If major surgery took place, moderate. Diagnosis or treatment significantly limited by social determinants of health, moderate. And it is high if drug therapy requiring extensive monitoring for toxicity. If a decision regarding elective major surgery with identified patient or procedural risk factors, decision regarding emergency major surgery, decision regarding hospitalization, decision not to resuscitate or de-escalate care because of poor prognosis, it is all high. So you might say, well, I got some questions, Mrs. J. What do you mean by, let me just, oh, I thought I pasted it here. I guess I didn't. I'm going to take a moment. If someone can place the link from slide 87 into the chat, I would appreciate it, because these are all, this is a document with your definitions. Earlier, I talked about definitions. You can find them in your E&M guidelines. They define all of these things like unique source. What is that? What is an independent historian? What is independent interpretation? They define it. They even define risk. And I'm going to show you in a moment. But let's get started. So in your handout, I'm asking one of my teammates to place the link for the handout. That's a document with all of the definitions. If you wanted just one hard copy definitions, it's right there. So you can find them in the chat. You can find these definitions in your CPT manual guidelines, and there you go. So in your handout or the CPT manual. Now, of course, I want to try and make things easier. So this is further instruction on how we're going to review documentation. So what I've just shown you is the way, it's the chart that AMA has created. I like the chart, but I love the AMCI chart better. It's a little easier for me to instruct and read. All right, so essentially, you have 3 columns that we've reviewed. We're going to need to review 3 things. We're going to have to review the problems, the number of problems, and the complexity of those problems. So pretty much the diagnoses. Number 2, we are going to analyze the data that the doctor reviewed. Yeah, what did the doctor do? And number 3, we are going to assess the overall patient risk. And we like to call our chart the PDR chart. And it looks like this. This is the AMCI PDR chart. The first column is for your problems, your P. The second, your data analyzation, the amount of and complexity of the data that the provider analyzed, and the risk. And the third is your level key. Wherever you end, wherever your code falls, then your level will be in pink. It's either going to be new or established. And our leveling instructions are here. Pretty much, if the PDR score, so if you have a score, if it is not an exact match, then you're going to throw out the lowest column, then code the next lowest column. All right. I think it's better if I show you. So let's get going. All right, so here are the general steps to assign an office visit based upon scoring the documentation to determine the medical decision making. Number 1, you have to have a medically appropriate history and/or exam. You're going to inventory your diagnoses, signs and symptoms, and procedures. You're going to score the PDR. You're going to determine the problems, data, and the complexity of risks. And finally, you're going to level or select the correct code, and you're going to use the MDM leveling technique to do it. So more specifically, this is what you'll need to do. Number 1, is it new or established? Number 2, did a medically appropriate history or exam take place? Number 3, go ahead and inventory your diagnoses, signs and symptoms, and procedures. And 4, score the MDM using the PDR chart. Oh, 5, we got a level. If the PDR is not an exact match, go ahead and level. And that's what we got to do. So now, are you ready to test your knowledge? Okay, it's not as straightforward as time, but once you get it, you're going to get it. It takes practice and you will get it. And I believe we simplified it enough that you should be able to feel comfortable very soon. All right, so essentially, I'm going to use the exact same scenarios as was used for time. So that's why I needed to correct the other one. All right, here we go. So it's the same scenario, so I'm not going to read it too much. The only thing I'm going to do, I'm going to highlight these key terms. All right, at the top, my instructions, the type, medically appropriate history and or exam, inventory, the scoring, and the leveling. So here are my key terms, the same as before: dyslipidemia, chronic pain, follow-up of lower extremity swelling, limited exam, labs and echocardiogram were reviewed. That's important. Bilateral lower extremity swelling, pulmonary hypertension, evaluate the etiology, and the patient will be scheduled for a sleep study. This looks a little different in terms of our keywords, right? Yeah, it's our keywords that look a little different because we have a different objective. We don't have time here. No. So we are going to score it manually because that's what we do as coders. So I'm going to walk you through this. Here you go. My instructions on the upper right. Number one, coders, is this new or established? Go ahead, type your answer in the chat. Yes, overwhelmingly, almost everyone. And I'm not saying everyone, there's not one person that said it, but most of you have said, hey, this is established. And you know what? If it was established when we had the first instruction, it has to be established for that same exact reason. We did this scenario before, and previously we learned that this is an established patient because this is a follow-up. Anytime you have a follow-up, and the dates are not documented. Let's say someone said, I have a 5-year follow-up. That's different, okay? So a general follow-up appointment when you're taking your exam is an established patient. That's a standard. So that's one thing we just got to know. Number two, did a medically appropriate history and or exam take place? Go ahead, type your answer in the chat. Good job. They are coming in, and some of them are even being specific. They said, yes, a limited exam was carried out. So, yes, it is medically appropriate. We know it's medically appropriate because the provider did it. Okay? So that's a good presumption. Now we have to inventory our diagnoses, signs, and symptoms and procedures. And this is how it is done. It's a little different than when coding for surgeries. Your procedures, you are going to document what the provider did or is going to do. All right? What they did or going to do. It's a little different for diagnoses, okay? You're going to see why. So if we document what the provider did, doctor carried out an exam. What else did the doctor do? The doctor reviewed labs, right? Yeah. What else did the doctor do? The doctor reviewed the echocardiogram. Anything else? Well, what is the provider going to do? The provider is going to schedule the patient for a sleep study. I'm going to let that marinate for a minute. Now, let's look at diagnoses. The diagnoses in this documentation, we have dyslipidemia, chronic pain, lower extremity swelling, diagnoses, signs, and symptoms, and pulmonary hypertension. And I wrote the etiology is unknown. All right. Next, we have to do number 4. We're going to score the MDM using the PDR chart. So we'll need our PDR chart. And the first place we go are the problems. What are the problems? Problems are diagnoses. Think about it. Your problem is your diagnosis. So the number of and complexity of problems addressed. Where are we going to get this information? All of our information is pretty much documented here on the left. If you said from the diagnoses list, absolutely. So we've got 4 items here: dyslipidemia, chronic pain, lower extremity swelling, and pulmonary hypertension. So let's start looking. Let's go to level 2. Do we have one self-limited or minor problem? Would you say this is we have one self-limited minor problem, or do we need to look at level 3? Go ahead, type your answer in the chat. Yeah, they say, hey, we need to go to level 3. Let's go to level 3. Do we have 2 or more self-limited or minor problems, one stable chronic illness, or one acute uncomplicated illness or injury? Do we need to go to level 4? Or are we okay with level 3? All right, some people say stay, some people say let's go to 4. Okay, so let's look at 4. 4 says you have one or more chronic illness with exacerbation, progression, or side effects of treatment. All right, so just so we're clear, exacerbation means worsening. So I don't see that, but I do see progression, right? So first, what is a chronic illness? A chronic illness is a condition that can last for a year or more. So dyslipidemia, chronic pain, pulmonary hypertension are all considered chronic illnesses. So we got 3 chronic illnesses. So one or more chronic illness with exacerbation, no exacerbation, progression could be, we don't know. The doctor said, hey, the pulmonary hypertension, um, the lower extremity swelling. Well, the doctor didn't say that, but that is something you'll learn. Lower extremity swelling could be related, but it's not definitive, so we're not going to do that. But I do think that we can look at the other ones. We have 2 or more stable chronic illnesses. I would say that if I already said we had 3 chronic illnesses, if they were unstable, the provider would have documented that it was unstable. So if it's not documented, the assumption is that it is. So we've got 2 or more stable chronic illnesses. We don't have a undiagnosed new problem. This new problem was diagnosed. We just don't know the etiology. We just don't know where it came from or what caused it. All right, one acute illness with systemic symptoms. Possibly, I believe that this pulmonary hypertension is an acute illness. It wasn't diagnosed before. It was diagnosed during this encounter. The systemic symptom, the lower extremity swelling, definitely a clinical indicator of hypertension and or one acute complicated injury. I wouldn't say that. But nonetheless, we have 2 or more stable chronic illnesses. So, ladies and gentlemen, we have moved on and up to level 4. Now, let's look at our data analyzed. We want to know the amount and or the complexity of the data. So we're going to get this information from the procedures, and we're talking about data. So we're going to bypass the exam. We have 1, 2 data reviewed and a scheduled sleep study. So we're going to bypass level 2. Let's look at level 3. And you must satisfy one of the categories, category 1 or 2. Category 1 says you need to review prior external notes. There's no mention of that. Ordering of each unique test. Wait a minute. He did schedule a sleep study. That is 1. Also, the doctor reviewed each unique test. Absolutely. The doctor reviewed the labs. That's 1 unique test. and the echocardiogram, that is 2. So we have 3 elements. So let's look down. Yes, if we look in level 4, any 3 from the following. Absolutely. We meet each unique test. We have 2, an ordering of a unique test. So I like level 4. There's no independent interpretation of tests. There's no discussion of management. If we go to 5, you have to have 2 of the categories. I like level 4. And finally, the risk. The risk. All right, so I'm just going to start at level 4 because this is where they have some examples for us. No prescriptions were written, no minor surgery took place, no major surgery took place, and no, the patient was not limited, diagnosis or treatment of that patient was not limited due to the social determinants of health. That wasn't a circumstance. So I'm just going to say we had a low risk. All right. I'm not going to say minimal because this patient has chronic conditions. And that is my professional opinion. And you know what, coders? You have one too. So, with that said, we have selected our problem. We said it was high, the level was high. The amount of data analyzed, that too. Is that high? Is 4 level 4? We'll just say it's a level 4. It's moderate, excuse me. Our data, level 4, is also moderate. And we said that the risk is a low risk. So, are you in agreement or do you understand, coders? Go ahead, type your answer in the chat. Okay, so we have one thing left to do. One thing left to do, and that is level. And the reason we have to level, see that purple over there? It says if the PDR is not an exact match and our PDRs do not match exactly, we're going to have to level. And to level, you throw out the lowest column. That will be our risk because it's a low risk. Then code the next lowest column. Next lowest will be the P or the D, and they're both level 4. So let's go ahead, throw out our lowest, then code the next, and we are at level 4, either 99204 or 99214. Based upon the fact that this is an established patient, our answer, 99214. Let's go back. How do you feel? Feel good? Now, if you're not sure, like, hey, I don't know if this and that, often it boils down to the definitions. It does. It really does. So I have one person that says they're good. One. If you don't feel good, say no. Oh, okay, they're coming in. Yeah, good deal. Some people, you guys are doing amazing. That's right. Somebody said I need practice. Absolutely, we all do. Yeah, this is new for us too. All right. And also, just take a look. This is the scenario that we did based on time, and they too have the same exact code. So if they have the same exact code, somebody might say, why doesn't the provider just document time on each encounter and eliminate the need for scoring? Isn't that a good question? Right? Because time is easier. We can just go ahead, select the time, and boom, we got it. But I'm going to tell you why we can't do that. But I'm going to get going. Here's our scenario number 2. Remember Susan, the 69-year-old female referred by Dr. R with a suspicious neoplasm of her left arm? She has had it for about a year, but it has grown a lot these last few months. The doctor had a privilege of taking the skin cancer off her forearm in the past. Didn't say when in the past, right? He did it in the past. Could have been 5, 10 years ago. Past medical history: hypertension, arthritis, no allergies, medications, Benicar and Vytorin, social history, cigarettes, none, physical exam. On examination, she has a raised lesion. It is a little bit reddish and is on her left proximal arm. It has a little bumpiness on its surface. Medical decision making: suspicious neoplasm left arm. My guess, it is a wart, but it may be a keratocanthum. 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 Miss Takima did a great job with that. As Dr. R thinks it is. After obtaining consent, we infiltrated the area with 1 cc of 1% lidocaine with epinephrine, performed a 3 millimeter punch biopsy of the lesion, and then I shaved the rest of the lesion off and close the wound with 3-0 proline. We will see her back next week to go over the results. All right, so I'm not going to give us any time. We're going to walk this one, and I'm going to let you do the next one. All right. So up at the top, these are our instructions, and I'm going to highlight my keywords. Referred by Dr. R. Suspicious neoplasm left arm. She had skin cancer in the past. Hypertension, arthritis, past medical histories, and then she had a suspicious neoplasm of the left arm, 3 millimeter punch biopsy, and then shave of the lesion and closed the wound with 3-0 proline. And that is the best I could do. And these are my keywords. Now I'm going to go on and I'm going to solve this using these instructions up at the top. Let me go ahead and put my procedures down and this indicates what the provider did or is going to do. The diagnoses are hypertension, arthritis, and suspicious neoplasm. So at the top, let's go in order. Is this new or established? This is the same scenario that I just reviewed, and we've determined that this is new because this patient was referred by another doctor. And you guys were talking about consultations. Don't worry about a consultation. I will show you exactly how to consider a consultation, all right? But we know this is new, and often consultations are new too. All right, medically appropriate history and/or exam. Did that take place? Go ahead and type in the chat. This might be hard for you to see, but it will give you an aha moment. You guys are rocking and rolling, rocking and rolling. And everybody said yes, an exam took place. You know how? See this little highlight right here? Physical examination. It did take place indeed. We have our inventory, and now we're ready to score. All right, let's begin with our problems. We have 3 diagnoses. We're going to get our problems from here, right? So we're going to bypass level 2. There's more than one self-limited problem. We're going to go to level 3. And you know what, coders, when you're able to say, is that a chronic condition? Yes. Is this a chronic condition? Yes. It's a chronic condition because it is expected to last a year or more, or for the life of that patient. So we know we have 2 chronic conditions. So let's bypass level 3. Anytime you have 2 chronic conditions, you're already at moderate. So we have 1 or more chronic illness with exacerbation, don't know that, but I have 2 or more stable chronic illnesses, right? They're stable because there's nothing in the documentation that says it is unstable. Stable is your default, all right? So I like level 4 because we have 2 chronic conditions. Also, let's look at the data review, the amount and complexity of data. I don't see any data. Do you? I don't. I don't see any. This provider is going off their own evaluation. So guess what? The data, which we will get from this procedures list, is minimal. Everyone with me? Good deal. Now, the risk level, I'm going to let you all tell me what you think the risk is. Okay. All right. So now this is going to be a teachable moment. The risk to me is level 4. You know why? Because if you look at this bullet point, this third bullet point, excuse me, the second bullet point, there was a decision regarding minor surgery, right? This patient had minor surgery, right? Yeah, he did a punch biopsy and shaved the lesion. So surgery took place. It was minor. So indeed, this is a level 4. All right. So what do we do? Go ahead and type in the chat and tell me, what is our level of service? Is it minimal, low, moderate, or high? Yeah, I see a lot of people saying it. Yeah. Yeah, it is moderate. You guys are leveling like a pro. You are, because the PDR does not match. We have a level 4P, a level 2D, and a level 4R. So therefore, they don't match. So we're going to throw out the lowest column, which is the D, and then code the next, which is level 4, the P and the R. Now, what is our code? Yes, 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 yes. Outstanding. All of you are saying 99204. This is a new patient. So if it's new, you code it 99204. How do you feel? Okay. I think AMCI has found an easy way to do it. So you guys got it. You all are scoring pros. All right, so I have my third scenario. All right, so here we go. Now, this you're going to have to do. A 14-year-old female patient with a history of cystic acne arrives to the dermatology oncology initial visit for treatment. She was referred by her general dermatologist, who belongs to the same practice. The provider carried out a comprehensive history and exam, reviewed the patient's chart, which contained a comprehensive metabolic panel, renal panel, thyroid panel, with skin biopsy. Final diagnostic statement: the patient has chronic cystic acne. All right. I'm going to give you I'm going to give you 2 minutes to solve. All right. You know what? Maybe not. I think I'm going to walk you through this, and here's why. You don't have the chart. Okay. So when you come to class on Tuesday, bring your chart. I'm going to make sure you get the most up to date copy. I had someone redo it for us, So hopefully I'll have a nice fresh copy that's very easy to read, all right? But you can do as much as you can. Remember our instructions on the upper right, and here are my keywords. History of cystic acne, initial visit for treatment. She's referred by her general dermatologist who belongs to the same practice. Comprehensive history and exam. Review the patient's chart, which contain a comprehensive metabolic, renal, thyroid panels with a skin biopsy. Final diagnostic statement, chronic cystic acne. Good deal. You all are doing it. They're saying, yeah, this is a new patient visit. Indeed it is. Outstanding. It's new because they said it's an initial visit. However, she was referred by her general dermatologist who belongs to the same practice. Doesn't say that this patient had, um, well, excuse me. It does say that the provider is a different has a different specialty. Dermatology oncology was referred by a general dermatologist. There's no mention that this patient was ever seen by this oncologist. So therefore, if it's not documented, it didn't happen. So this is an initial visit. All right. Now, if they were the same exact specialty and the same exact subspecialty, this would have been an established patient. I digress, but I'm back. Now, did a medically appropriate history and or exam take place? Absolutely. You guys are saying yes. Yes, it says that this patient had a comprehensive exam. Yes, indeed it did. Remember, it is the discretion of the provider. And I don't know any provider that will say a medically inappropriate history and or exam took place. Okay. All right, so let's go ahead and inventory. We'll begin with the procedures. This is what the provider did or is going to do. He did a comprehensive history, comprehensive exam, review the comprehensive metabolic panel, and if you look at your handout, panels are all considered one test. So the comprehensive metabolic panel, the renal panel, the thyroid panel, and reviewed the skin biopsy results. That's four things that took place, right? The diagnoses, only one, chronic cystic acne. All right, so let's go to our number and complexity of problems. Our number of complexity of problems addressed, we only have one. I'm going to bypass level 2 and I'm going to level 3. We have one stable chronic illness, right? You all in agreement? Good deal. So we have one stable chronic illness, that's a level 3. Now let's get down to the data. Let's always start, if when you have data, always start at level 3 to save you time. All right? So there is review prior notes from each unique source, review of the results of each unique test. So I like reviewing the results of the comprehensive metabolic panel, renal panel, thyroid panel, and the skin biopsies. So we have 4. So I'm moving down to level 4. All right. So if we look here, level 4, I like level 4 because we have at least 3 of category 1, no category 2, no category 3, and all we need is to satisfy one category. If we're not satisfying categories 2 and 3, then we can't move on to level 5 because you need at least 2 of the categories below. So I like level 4. And now our risk. Okay, coders, what say you is the risk? Go ahead, type your answer in the chat. And it's subjective. Yeah, so a lot of people said low. I just said minimal. It doesn't matter if you said low or minimal, they're both correct. And so, with that said, what is the level of service for this encounter? Okay, so we have to level, right? This technique is leveling. So if the PDRs don't match, you throw out the lowest. So the lowest could, if you said minimal, you're going to throw that out. If you said low, you're going to throw that out. And then you code the next lowest column. So let's go ahead and throw it out. The next lowest column is 99203. And you guys rocked it. Rocked it, rocked it, rocked it. Outstanding. So I bet you thought I forgot that question, because every single encounter that was coded with time as well as MDM, they matched exactly, right? They matched. So why doesn't the provider just document time on each encounter, right? I'm going to tell you why. Nobody even said right. They just said, yeah, someone said, okay, good. It came through late. All right. So this is why I have this scenario here. This patient with a history of hypertension and diabetes mellitus arrives at the physician's office for follow up. The physician carries out a limited exam and writes a prescription for metformin, treating her diabetes and lisinopril for the HTN. The total time of the encounter was 15 minutes. What is the appropriate CPT code? Well, we know that this is an established patient. We know that a medically appropriate exam took place, right? We have a limited exam. Follow-up is for your established patient. Now let's go ahead and inventory. What did that provider do? Provider carried out limited exam, wrote prescriptions. What are the diagnoses? Hypertension, diabetes, right? So let's go ahead and determine what our MDM is. All right, so we said if they have two stable chronic conditions, that automatically takes us to a level 4, two or more stable chronic illnesses. So we have a level 4 problem. Our data, the only thing that this provider did was write prescription, so our data is minimal. We got a level 2 data. But this provider wrote prescriptions. And if we look, prescription drug management is indeed writing a prescription. So we have a level 4 risk. So if we go ahead and level, we're going to throw out the lowest, code the next, and this is a level 4 encounter. And that level 4 encounter is 99214. It's a follow-up. But if we code this based upon the time of 15 minutes, and you can use this level key for time, so let's go find 15 minutes. 15 to 29 minutes is 99212. Oh my goodness, I made a little blunder. So let me fix it back here. All right, so 15 to 29 minutes is 55212. Oh, it's 99212. So let's go ahead and right, if we code based upon time, this encounter would be 99212. However, if we scored the MDM, this encounter would be 99214. And the difference in the real world between a 99212 code and a 99214 code can be about $150. So if it's $150, let's say a provider does a lot of medical management, like behavioral medicine doctors, if they were coding 99212 and we come in and we scored 99214, we've just made profit for that practice in excess of 30% based upon our ability to score it. And you know what, ladies and gentlemen, this is the difference between a biller and a coder. A biller would just put that time in the system and go because they don't know how to level. But you do. Someone said, hey, can I put that chart in my book? You sure can, but you might not even need to, you might just be able to use their chart because it's already in there. It's up to you. And yes, I'll show you how to tweak your chart. All right, there you go. So the key to success in MDM scoring is understanding the definitions. And don't forget, click on your handout and look at your definitions, and those definitions are still in your CPT manual and always will be. And that means you're going to carry them with you to the exam. However, you're not going to need to look at them. By the time you do all of the scenarios, you're going to kind of know them. All right. So this is what the definitions look like. They define problem, problem addressed, minimal problem, self-limited or minor problem. What is a stable chronic illness? What is acute uncomplicated illness or injury? Chronic illness with exacerbation, progression, or side effects of treatment. Undiagnosed new problem with uncertain prognosis. What is that? What is an acute illness with systemic system? What is an acute complicated injury? What is a chronic illness with severe exacerbation? What is an acute or chronic illness or injury that poses a threat to life or bodily function? What does analyzed mean? What is a test? What is unique? Combination of data elements. What is external? What does that mean? What do they all mean? CPT defined them all. External physician or other qualified healthcare professional. Discussion. Independent historian. What is that? Independent interpretation. Here is the definition. External physician or other qualified healthcare professional. What is that? Discussion. What is that? Independent historian defined again. Independent interpretation. And your risk. What is an appropriate source? And what is a risk? Morbidity, here's the definition: moderate social determinants of health. Surgery, all are defined here. And morbidity, same thing. This is major health, so we're going to keep going. And then finally, drug therapy requiring intensive monitoring for toxicity. What is that? So the important thing is, if you are not sure, go to the definition and make sure that you read it. And don't read into it, read it. So what the definition is, that is guideline. Take it as such. All right. All right, so now that you have learned how to select the appropriate level of service for office or other outpatient encounters, specifically codes 99202 through 99215, let's go ahead and take a look at how to look at prolonged services. Prolonged services codes. These codes pertain to office visits and other encounters, and they are they are used anytime the service is beyond the usual evaluation and management encounter. So these are time-driven codes. Yes, time-driven codes. We love time in E&M because they're straightforward. Now, there are four classification of codes. You have prolonged services with patient contact, prolonged services with outpatient contact codes, prolonged services rendered by the clinical staff, and prolonged services in the outpatient in the office. So pretty much this 99417 is used by doctors, all right, in the office, doctors in the office. All right, so the first classification of codes with patient contact is divided in terms of outpatient and observation and inpatient, right? Outpatient and inpatient, but not office visits. This outpatient is not office visit. The next, with outpatient contact, this is also pretty much everything except office visits, but this is without the patient being there. And the third, this is for the clinical staff, like the medical assistants, the technicians, etc. And finally, this 99417, this is doctors' prolonged services in the office. And that is the difference between them all. And the best part about these prolonged services codes in each section, they have these nice charts that help you determine how to select the code. So if we have direct patient contact, this is what you'll code it as. I love it. If it's less than 30 minutes, you don't use it, 30 to 74 minutes, and so on. And now let's take a look at the codes up close and personal. So prolonged service with direct patient contact, except office. You don't use these for the office or other outpatient services. So you're saying, well, if you don't use it for the office, what do you use it for? If you read the code, it'll tell you every single encounter you can use it for and not to use it for. But just in a nutshell, this is outpatient setting, not the office. Psychotherapy visits, like that, therapy visits, consultation, home visits, you can use these prolonged services codes. So the first family is for outpatient, face-to-face patient contact, no, not in the office. The next family, this is inpatient or observation, face-to-face contact with that patient. That's pretty much straightforward. Now, the first code, and remember, they're all add-on codes, but the first code in the first family is for the first hour. The second code is for each additional 30 minutes, but if you read the guidelines really carefully, they really mean you can use this code for each 15 to 30 minutes, okay? Each 15 to 30 minutes. So if you want to go ahead and chun your book or just write that down, and you don't have to do it now. Just watch the playback because I know this is a lot of information. Okay. And do not use any of these codes for office visits. Don't use any of these right here. All right, so now let's take a look at prolonged service without direct patient contact. They have two codes. The first code is not an add-on code. The second is, and they have their chart. I love it. If you follow the chart, you're good. Now, prolonged services carried out by the clinical team. This is not for the physician, but their staff, their technicians, their nurses, their medical assistants. They have their two codes, and this is their prolonged services codes, 99415 and 416, and this is their code up close and personal. So pretty much the key is you use this for the clinical staff. And that clinical staff, of course, has to be supervised by the professionals in the office. All right. And finally, prolonged services with or without direct patient contact on the date of an office visit. This is the code 99417 that's used by the doctor or qualified healthcare practitioner. And here is their chart, coding chart. And let's look at that code up close and personal. All right. And it tells you use this code in conjunction with 99205 and 99215 only. And they're telling you not to report this code with the others. And here are all of your classification of codes at a glance. Are you ready to test your knowledge? I think so. I think learning, knowing is to doing. So let's just do it. All right. So I'm going to read the answers first. A, 99214, 99417. B, 99214, 99415 with a 59 modifier. C, 99214, 99415. D, 99214, 99417, and 99415. Chief complaint, losing concentration, problem list, anxiety and depression, clinical service. A 30-year-old with complaints of inability to focus and lost concentration. She has a history of anxiety and depression, but lately has been unable to focus on one project at work. Huh. After a moderate level MDM, that's medical decision making evaluation and management encounter, the psychiatrist recommended that the patient undergo a computerized neurocognitive assessment called CNS vital signs. The test was administered by the medical assistant, who was managed by the physician. The test took an additional 1 hour beyond the office visit. All right, what are the CPT code or codes reported? All right, so I'm going to let you do this one, coders. Let's do it. So go ahead when you have your answer, type it in the chat. All right, you all are rocking. And I hate to kind of rush, but I want to get a little more in. All right, so here are our keywords. Chief complaint. This is the reason why they say they're coming in. They're losing concentration. The problem list, anxiety and depression. This is something that they've been dealing with. All right. Inability to focus, lost concentration, history of anxiety and depression. After an MDM, a moderate MDM, that's 99214 we learned today, right? The physician recommended the patient undergo a computerized neurocognitive assessment called CNS vital signs. This test was administered by the medical assistant who was managed by the physician. The test took an additional 1 hour beyond the office visit. So let's go ahead and we see that A, B, C, and D all share the same first answer, 99214. This is your office or other outpatient visit, moderate level of medical decision making, right? So we know that's correct. Now let's go on and look at these secondary codes. All right, so I'm just sidebar tell you. Remember we said that 99417 can only be used with 99205 or 99215, right? Yeah. So they are coding, A is coding 99214 with 99417, and so is D. So those two are eliminated right away. But let's go back. But if we look at our options of the four, it would seem like 99415 and 99416 would be the correct, because we have to code for the prolonged service of the clinical staff. Remember, the medical assistant administered this exam, right? So if they administered that exam, we need to go to their chart, to the clinical team chart. This is their chart. Sorry, I don't have the heading here. And it says that the test took an additional 1 hour beyond the office visit. We already coded for the office visit, so let's look for our 1 hour. And 1 hour falls within 45 to 74 minutes. And it says we're going to use 99415 one time, and that's it. And you know what? C is our answer. And the reason why B is not our answer, because C is an add-on code. You don't put a 59 modifier on an add-on code. Just thought I would remind you. Now let's move on. We have another scenario. It's not different, it's the same, only the physician carried out the test. And if the physician carried out this test, it's going to look like this. You're going to go to the prolonged services code with or without patient, I want to make sure I have this right, with or without direct patient contact in the office. And our answer, let me see if I have the answer here. I don't even know. Let's see. So our answer has to be, oh, okay, I don't have the answer. So I want you to tell me, coders, what is the answer? Is it A, B, C, or D? It only can be one based on a guideline. Nope, it's not C. Your answer has to be, it has to be D. And the reason is because you cannot use 99415 with D. And I apologize, you cannot use 99417 with any other code other than 99215 and 05. And I did fail to point out this. There was a complex level MDM. Complex level. I'm sorry I'm rushing a little bit, but hopefully you understand that when a physician has a prolonged service, you can use 99417, and it is only prolonged if they've exceeded the time in 99215 or the MDM. There you go. All right, so here is the last one. History of a 24-year-old female patient who attempted suicide by sleeping pill ingestion was admitted into observation before being transported to the mental health facility. Currently in the facility doing rounds, the PCP, primary care physician, visited the patient in the observation unit. Concerned that the patient may be experiencing residual neurological effects resulting from the ingestion, at bedside, the PCP carried out a comprehensive history and exam. He reviewed the following in the patient's chart: the ECG, EKG, toxicology report, final diagnostic statement, suicide attempt, chronic nervous twitch of unknown etiology. The decision was made to admit the patient to the hospital for further testing. Prolonged time, 1 hour beyond the evaluation and management service. All right, so I'm going to walk through this. Patient attempted suicide, sleeping pill ingestion. Patient was in the observation, going to be transported to a mental health facility. Then the PCP visits the patient in the observation unit and at bedside. So that means some face-to-face was going on, right? Comprehensive history and exam. Review the patient's chart. Attempted suicide is the final diagnostic statement. Chronic nervous twitch, unknown etiology. The decision was made to admit this patient into the hospital. Prolonged time, 1 hour beyond the E&M service. Now I'm going to let you tell me what is your answer. All right, you all are amazing. I got lots and lots of answers in the chat. All right, so this is what we came up with. Well, we know that A, B, C, and D all have the same answer. And for those of you that are advanced in coding, you know that we're going to code initial hospital. We're not going to code observation. And you know what? We're going to learn on Tuesday why you're not going to code the observation. We'll talk about that later. But initial hospital care is our first code. Now we have to code for the prolonged time. And of the four, which is the code series that we're going to code? Prolonged service with patient contact, without the clinical team, or prolonged service in the office? Since I say it like that, it makes it easy, right? Yeah, we're going to get our codes. One person answered. So yeah, two people answered. Come on, where are we going to get our codes from? 1, 2, 3, or 4? Maybe I'm just lagging here. Yeah. 100% of you said, yeah, we're going to grab our codes from the with patient contact, right? Yeah. So we can just look down and see which one kind of falls in the right category. So if we look below, 993, 56, and 57 is the family for observation or facilities, inpatient and outpatient. So you know what? This patient was admitted into the hospital inpatient, and this is exactly where we're going to get our code from. 99356 family. So let's go in and see the codes. We look at the both families. 99356 is coding for inpatient visits or observation setting visits, the first hour. We don't need an additional 30 minutes because we're only coding for 1 hour beyond. Okay? We're not coding 99354. That's for outpatient stuff. Uh-oh. So our answer is C. And if you said C, 99223, 99356, outstanding. You got it? Yes. All right, so I'm going to ask Mr. Kima just to do one scenario with you, exam-like scenario, and we will revisit these on Tuesday. Ms. Takima, take it away.
Thank you, Mrs. J. Coders, here is our final scenario for the day. Answer choice A is 99212, B is 99213, C is 99214, and D is 99215. This is an established patient office visit. Chief complaint is left tibia fracture, history of present illness. Patient is 13-year-old male who we first saw on 4/24. He was noted to have been injured when he jumped and fell while running down a hill. He sustained a Salter Harris 2 physical fracture of the distal tibia. He is currently non-weight bearing in a short leg cast. He has been compliant with his activity modifications. His physical examination, he is intact to sensation. His capillary refill of the toes remains stable. There is no skin breakdown at the proximal or distal aspect of the cast. The cast is intact. Ancillary studies, radiographs ordered, performed, and billed in our office of the left ankle, May 8th, 2000 something, show good alignment and positioning of the fracture. Growth plate is stable. Impression, left distal tibia fracture. Plan, he will continue to use the cast, maintain non-weight bearing status, return for assessment with the new x-ray in 2 weeks. Cast care instructions are once again being reviewed. What E&M CODIS reported. CODIS, you'll get 1 minute and a half for this one. Hey, CODIS, that was 1.5 minutes. If you have your answer, go ahead and place it in the chat. If not, go ahead and keep working and we will work through this one. So for this one, our keywords are his chief complaint was that left tibia fracture, Salter-Harris 2 physical fracture of the distal tibia, short leg cast is what he has. The doctor ordered radiographs. He performed and billed it to the office. The growth plate is stable. Impression is left distal tibia fracture. And he will continue use of his cast, non-weight bearing status activities for now, and then return for new x-rays in 2 weeks. Your answer there is 99213, and I think that most of you guys were going between that one and C, so we'll look at it. So if we look at it, if it's typed it's new or established, it is an established patient. Procedures that the doctor did: he examined the cast, he ordered the radiographs, he read the radiographs, the x-rays in 2 weeks, more x-rays in 2 weeks, and the diagnosis was a left tibia fracture. We have our established patient codes here, the 992 ones. And if we look at this one, 99213 is office or outpatient visit, which requires medically appropriate history and exam. And then if we look further at our chart, we have level 3. So if you're looking at your chart, he has one acute illness, which would give us level 3. The doctor ordered the radiographs. The doctor read the radiographs. He reviewed from prior history notes, so that would give us a level 3 also for that one. Then for our lost my train of thought. For our risk, the risk would be pretty low. He only has a tibia fracture. It's not really complicated by anything except that he can't put his weight-bearing activities on it, and so that's a low. So if we were to get rid of, since we have to level, we get rid of the lowest column and we choose the next, with it being the 99213. So if time is all you're given, yes, you would go by the time. If time was given, but then you can, I don't want to say upcode, but you can code to a higher level based on the documents, you can do that. I don't know how in-depth the test goes with doing that part. So I would just either focus on time if they just have the time, or the leveling if there is no time. I wouldn't worry about if there's time and leveling. Okay, so you guys did an awesome job on that, and that was our last scenario. Give me 1 minute to get your homework for the day. Tell us how you guys feel about that. Hopefully you guys are feeling better about leveling. It takes a while to get used to. Once you get used to it, it's pretty good. Okay, so today we did review on your document. The key points to score an MDM again is to review your documentation, use the AMA definitions for clarification purposes, select a good scoring tool, and remember that it only pertains to office visits, your 99202 to your 99215 codes. If for some reason you also did not finish watching the lectures, please make sure you do that. Why is my slide not advancing at all?